Shalom. We are streaming live we're global. It blows my mind. I'm Dr. Tova Goldfein from Israel. It's 10 o'clock here. My amazing Wonder Woman co-host is going to say hello and tell you where she's streaming from. Good morning, Rose.
Hi, Tova. Good morning, Michael.
Good morning.
Welcome. We've got Michael from Florida today, and he's going to talk about early childhood trauma, the connection with chronic pain, TMS, and also the connection with, the word's gone from me. Michael, what is it? PTSD. Yes. Michael hails from Florida, and I will put his email address on the bottom of our page later. Now, also, this may bring up strong feelings with you all. I'll be on the computer for the rest of the morning. It's 5 a.m. in Australia, and I will also give you Michael's contact details and ours. And you're welcome to email me or message me or whatever. And remember that we're on about love. The childhood trauma happened, but in a child's heart there is love. And Michael's going to help us explore some of that, the love that's been neglected. Over to you, Michael, and welcome, and thank you so much, because this is so much part of a TMS journey about understanding their ACEs. Thank you.
Yes.
Yeah, thank you so much for having me. It was a wonderful meeting with you guys last week, and I'm very much looking forward to today. We may start off on some rough material, but my hope is that as we move forward through the conversation, people will find a sense of connection to hope and possibility and perhaps a future vision they could not have thought of before.
Beautiful.
All right. Okay.
Yeah.
So luckily I'm here to talk about adverse childhood experiences, which is there's a lot of gravity to that terminology. I figured what would be a good start was to give everybody a rundown as to what adverse childhood experiences consist of. Commonly, it's referred to the acronym ACEs, which covers 10 items, which have to do with 3 domains. One is abuse, the other is neglect, and the third is household dysfunction. So generally, ACEs is a 10-item questionnaire a person will fill out, and they endorse yes or no to each of the items. So for abuse, it'd be physical abuse, sexual abuse, and emotional abuse. For neglect, it'd be physical and emotional neglect. And then the last 5 items have to do with household dysfunction, which consists of parental separation or divorce, household substance use, domestic violence, household mental illness, mental health issues, and a family member being incarcerated. So all those together consist of the 10 ACEs. Okay. So ACEs, it was a study that started a few decades ago back in the 90s, which pretty much a lot of health practitioners started to realize that many of their patients who were coming in for issues like chronic pain or health difficulties like high blood pressure, also cancer, tobacco and alcohol use, so on and so forth, they were finding that a lot of the patients were reporting a prior history of childhood abuse and neglect. So this questionnaire was started in order to give people like a simple, straightforward 10-item questionnaire that could provide practitioners with a great deal of insight as to what the childhood experiences individuals were going through beforehand. And through lots of research and lots of questionnaires being filled out, studies have had up to tens of thousands of people fill these out. They have found incredibly strong correlations with exposure to childhood abuse and neglect and household dysfunction being linked to a significantly lower life expectancy, chronic health issues, chronic pain difficulties, co-occurring mental health issues, substance use, and down the line. And what they find most importantly with ACEs is, as I described, there are 10 items. So if you are endorsing progressively more items, you are at a greater risk of specific health difficulties and mental health issues. So far, so good, guys?
10. Good.
Excellent. Yeah, it's true. We see it all the time, don't we? When people come to therapy, and in the type of therapy I use, I don't go there, but the patient eventually goes there. So I don't ask those questions because I'm looking at the present moment and the difficulties in the present moment. And then with ISTDP, they start noticing, yes, this happened to me much earlier on. You know, it's mostly household dysfunction that I see with my patients, some abuse, and also some neglect. But household dysfunction seems to be the primary thing out there in the general public. This is why I say it's about love all the time. And as Michael said, it's about hope. Hope that when you realise that it has never been your fault, I think that's the most important thing. That's where the hope arises, I think, Michael. That it's not the patient's fault. What do you think about that?
I agree in terms of my work with clients. Generally, I work with individuals who have a long history of traumatization or complex trauma. So they were exposed to multiple forms of abuse and neglect throughout their life. For a lot of individuals, they feel a sense of self-responsibility for what they experience.
Yeah.
And usually most of the time because we just don't know any better when we're growing up as children.
Well, not so much that we don't know any better. We haven't got a connection to that area because we think everything's our fault, you know. You know, would you stop being so noisy? You know, what was that saying? Children should be seen and not heard.
Right.
Yeah.
A 19th century concept that's still around. So,
Michael, can you tell the story? Can you tell this? Maybe Rose and I chatted about this. You told us the story about the patient of yours that didn't have his parents check his homework. It's just so profound because it gives a good example to us that it doesn't have to be an abusive situation, but it can be, even neglect is a strong word. You know, and we're all parents. I mean, Rose and I are parents, we're grandparents. Like, we're not here to like talk about, you know, negative things. We're here to just notice, recognize. I happen to think forgiveness comes in there somewhere because parents ultimately do the best they can. But if you could chat about that so people can walk away with, you know, parents is a tough job. There's no book.
Yeah, no one gets the instruction manual in the mail on that one.
Right.
Well, they do, but it's the wrong one. They get the instruction manual, but I'm going to know what's going on in my head.
They practiced on the first 5 kids, and then, I mean, I want to do it over being a grandmother. I want to do it again. You know?
Well, Rose, what you described, I think what I'm about to share will connect with in terms of when you start working with clients. It's always cautious to not dive right into traumatic experiences, but more to get an idea of what a person's upbringing may have been like, such as the context. And that's where household dysfunction will usually come into play. So I shared a story last week with you guys talking about how I'd worked with a client, and many clients have this kind of experience where they'll talk about growing up and how great a job they did with school. And that, you know, they stayed in school and they did what they had to do. And I'll ask a question, you know, just to kind of like explore cautiously at first, like, well, what did your parents think about your schooling? What did they think about your schoolwork? And inevitably, for many people say, my parents never asked me about school. I just got it done. And then I'll ask, you know, wait a minute, your parents never checked in on your work. They never asked how you were doing in school. I had one client share with me one time that they used to forge signatures in their homework book throughout all of high school. And they were smart enough to know that they did it on the first day, so the teachers would never know beforehand what the actual parent signature looked like. And they got through all of high school, graduated. They're a very successful adult now. But in reflecting on that experience, it was like, wait, your parents never checked all those years? They never asked? And the person said no. And it was like a moment to reflect and think about that kind of sense of autonomy we have in childhood and adolescence, that sense of responsibility that we can do it, we can take care of that. But that sometimes in and of itself can lead to some difficulties people have as adults.
Right.
And that's where they take on that responsibility for other people, isn't
Yeah.
it? Yeah. And they think that they're responsible for everything. And then it's almost like that back pain is a weight on their shoulders or on their hips for the sake of for the amount of responsibility that they're holding on to in their own lives then. And then, of course, they come to the doctor and they go to the physiotherapist and they do this great round of people and no one can cure them. And it's all about they trying to be the best they can, and then they fall apart with pain. Michael, talk a little bit about PTSD, because I think that's connected quite strongly, but probably a little bit unrecognised with patients that have got TMS, chronic pain.
Yeah. So first, I'll just lay out, traditionally, PTSD, it's defined by a set of criteria, the first of which is an exposure to a traumatic event, like a life-threatening event or an intensely abusive event, car accidents, so on and so forth, and then corresponding criteria of symptoms. So you'll have like hyperarousal, hypervigilance, avoidance of settings, avoidance of people, avoidance of life in general, because it may trigger associated traumatic experiences or traumatic thoughts. You'll have negative thoughts in terms of your self-concept, so low self-esteem, negative self-concept, feelings of worthlessness, so on and so forth. Dissociation is an incredibly common symptom and common factor for PTSD. So a lot of people, in order to avoid the pain, the emotional pain, the psychological pain, and at times the physical pain associated with trauma, dissociation is a way to protect ourselves and develop distance and space from that. Especially when it comes into ACEs research, what's found, and I find this with clients I work with and studies I've done, is that individuals who present with PTSD symptoms, right, the criteria I described, so many tend to have reported multiple ACEs. So they're reporting 2, 3, 4, if not more ACEs throughout their childhood. So they've had to deal with perhaps exposure to abuse, neglect, and predominantly the household dysfunction piece we kind of brought up a minute ago.
Yeah. Can you sort of, I don't want to say advice, but I do want to say advice.
Let it fly.
What would you say?
Tools.
Okay. What would you say to people to acknowledge the PTSD and release it or let it go in the present moment? Anyone who's watching us at the moment who has reported ACEs and reported PTSD, what would you say to them? Michael uses a different group of therapies to deal or help patients, and I'd like him to sort of like talk a little bit about that, so that people will get an idea that it's curable, that it's not a problem that you've got. It's a problem that you had to solve when you were very young, and now the problem is still hanging around.
Yeah. There's a great deal of options out there. First of all, it can be difficult to recognize at times the kind of difficulties a person is having. So perhaps it may be best is like there are many resources online that provide checklists or reference tools that you can look up, support resources on various websites, which I can also provide via email. But just to become familiar with perhaps the symptoms or just the difficulties you're experiencing, and just to recognize that. I think one of the first and foremost tools is therapy, both individual and group therapy or support groups. For a lot of individuals who have PTSD or complex PTSD, for that matter, have had to deal with chronic sadness, chronic loneliness, a chronic disconnection from others, chronically low self-esteem, and not as a byproduct of their own doing, but just because for many people they've been surviving and doing the best they can. So sometimes there's this ingrained notion, myself included, is like I have to do it on my own. I have to be alone as I get through this, which is not the option. Not the option.
Mm-hmm.
At times that's an artifact of surviving in the past and having to bear it alone. But now is the time. There are so many people out there working together, providing information, resources, and support, so that you can have a sense of connection. And that's a very solid foundation for a journey to healing.
Mm-hmm. So therapy is one. What else?
Therapy,
again, talk therapy, a certain kind of therapy. It depends on the person. I mean, we're finding that talk therapy isn't really working because we're so intellectual, we're so in our head, we're so in our thoughts, we're so cerebral, you know, and we've got this problem, so Rose and I are finding a lot of success, when we sort of go away from, less talk and more accepting, more understanding, more recognizing. So
mind-body connection.
That's it.
Yes.
Let's get right to it. Right to the mind-body connection.
Listen, I'm all about, look, there are people that read the book that didn't even say a word and they got better. They read Sarno's book and they didn't even talk to anyone. So it depends on the person. But we have been finding that people, will just get wrapped up in their thoughts, in their head, and it's pushing them away from themselves. It's like a distraction. Rose would call it a defense. And take them away from where they need to be. Can you address that?
Yeah, and that's akin to dissociation, right? Because a lot of the times people become so internally and inward involved in what's going on in their minds, and in a way, sometimes that's more familiar. So a lot of work is about getting people back to just experiencing being a person, being in a body, and
That's right.
especially with chronic pain.
Say that again. Being in their body.
Yes.
Disassociation is they're out of their body more sometimes. Isn't that what disassociation is? They don't.
Well, they're in their head.
In their head.
Because your head holds you, and you can, when you're in your head, you can see where the danger is going to come, and you're always prepared for the danger in your head. Whereas when you're in your body, your vasovagal system is relaxed, and you're able to be yourself. But when you're eternally vigilant, you can never be in your body. So undoing the vigilance is probably one of the key areas and of self-healing. But akin to that, what I was noticing with Michael is the connection with the therapist or with a loved one, that you can allow that loved one or the therapist or whatever to actually bring you to that safe place. Can you talk about that a little bit, Michael, and how hard it is for someone to trust anyone with PTSD?
Okay, so trust and distrust. So we're talking about the body and connection with the body, right? And that's very important when it comes to traumatization, dissociation, chronic disconnection, right? There's different modalities, therapy. There are a realm of modalities that can help one developing the capacity to just relax. It's so understated what the ability to just practice relaxation can do for helping you reorient to being in your body and not being so heavily involved in your thoughts and thoughts of being harmed or fear that will lead to you being hypervigilant and avoiding, let's say, like taking care of yourself and feeling more connected to yourself and those around you. So in therapy, it's a safe setting to be able to do these practices, to learn from a practitioner so you can be guided, because at times there can be a risk that through relaxation, uncomfortable emotions and feelings will come up, which can be useful when digested and processed in a safe environment, right? And that can help free up a lot of types of pain, whether that's psychological, emotional, or physical pain that's being held in the body. Distrust, Rose, that's such an important component. And it's such an emphasized component to therapy, because when working with people who have been exposed to whether that's one ACE or all of them and in between, individuals who have had to experience traumatization, is that there is chronic distrust, and for good reason. If you've had to develop through life with a lot of difficulties and conflicting relationships, so on and so forth in development, being afraid to trust is a protective mechanism from being harmed again.
That's right.
So therapy, and with therapists, a great deal of therapists are educated in this, that they want to take time so that themselves and the client can develop trust slowly to work and to do the work like relaxation. Because even for those with trauma, to sit in a room with a stranger and practice relaxation might be the most antithetical idea anyone could posit to them. I've been through hell, and you want me to sit and trust you and relax? Complete opposite of everything I've learned in life.
Okay, so I have a question. Okay, so I'm talking to my therapist, and I'm getting this relationship is positive. I'm feeling really good about it. I'm feeling trusting. Let's say I'm feeling trusting. I want to take this relationship, and practice it, outside. So I often feel that the therapy session is once a week, and then we go out to the world where all the lions are that are about to, pounce on us, and all it is a toy lion. But anyway,
Yeah.
so because of my nature, and Rose and I have talked about this. So what I like to tell my clients and my patients is, what can you do at home? How can we support you at home? And sometimes patients will be like, well, can I call you every day? And I'm like, well, that's another defense, that you're the doctor, you have the doctor in you. So we try to encourage and support our patients, but I like to sometimes give them some tools at home. So I have this trusting relationship with you in the office. What can I then do all week to go home and experience that trusting relationship in my life? What are the tools that I can take with me? Aside from, I call it like learning a new habit, because aren't we teaching
Yes.
people to learn a new habit and a new relationship with themselves?
Yes, trusting themselves in a new way.
That's the first step.
Yeah.
That you are trustworthy. Yeah.
Well, I may sound a bit rigid when I say this, but it's practice, which can sound absurd to individuals who have been chronically stressed and chronically overwhelmed. Is the idea of like, wait, you mean I need to practice relaxing? Yes. You will get so much out of life and your therapy as you develop the ability to modulate your stress, which for a lot of us, we've grown up in stressful households, we've had to develop in stressful lives, and we're stressful adults. So the one thing we haven't practiced much of, in fact, is how to relax. And hey, I'm a fan of watching movies. But 8 hours of watching Netflix, that's not relaxation per se, as much as just like a friendlier form of dissociation and checking out a
That's
little
what
bit.
it
Or
is.
distraction.
Distraction, yes, it's very adaptive.
It's a
Distraction.
defense.
Right.
It's a defense
Yeah.
against emotional closeness, but the emotional closeness is to yourself.
Yes.
And when you're sitting watching Netflix, that's what it is, isn't it? Keeping away from your own thoughts.
And we're talking about balance. There's nothing wrong with, I always talk about donuts and tofu.
We're talking about
balance.
10 hours.
Wonderful.
It's about balance.
Wonderful.
But Michael, can you also talk about, I lost my train of thought. So we're talking about meditation and relaxation and
Relaxation.
Right. And go ahead, speak more.
I want to say this is that when it comes to relaxation, and I experience with clients I work with, because a lot of times it's just like, let's just talk, let's learn to feel safe in a room together, because that's the first thing you have to develop. And then it's, well, let's practice together, because for a lot of people, the idea of practicing and breathing for 5 minutes could be a very incredible task. And approaching it with, perhaps a more rigid or authoritarianist type approach is, oh, you have to do it, and you have to do this, you have to do this. When you sit with a person and they feel safe and they practice breathing with you for just a few minutes, for a lot of people that have been through chronic difficulties and chronic pain and hurt, is feelings of sadness. So for an individual to sit and practice means they're going to have feelings come up, and those feelings of sadness come up. And for a lot of people, they don't want to be alone when they feel that sadness. So at first, it's developing in the therapy the ability to practice how to hold those feelings, reflect upon them, how to utilize relaxation practices that don't have to be oriented towards discomfort or uncomfortable thoughts and feelings. There's distraction techniques that you can use for meditation, such as like a hobby. There's a lot of artwork people do that's meditative in and of itself, that you can focus on breathing and just being in the moment. Music is great. I mean, there's so many resources, and different tension reduction exercises are really important. We hold so much tension in our body. A lot of us are so chronically used to holding tension that we don't even realize we've been walking around like this for months, if not years on end.
So tension reduction practices. People struggle with meditation. It's something I practice. Myself, I practice. So when they're stuck on the meditation, can you talk about a few? First of all, tension reduction practices. It's a new way to put it, but okay, I'm stuck on meditating. I can do it great with you because I like your voice and I can listen occasionally to it. But what do I do, doctor? I'm just not able to do it at home. My thoughts are racing and I keep thinking about everything else. And what do you suggest?
Great point, because a lot of times it's almost the feeling that it can only happen in the therapy. And what we want for effective therapy is we want what's happening in therapy to translate outside into life, which you mentioned, with the lines and the toy lines aside.
Right.
And to be able to have that, because that's going to develop a sense of autonomy and being able to live more freely when you can help modulate your own stress. So again, maybe perhaps like sitting and practicing, going the route of just sitting monk-like and just breathing and nothing else can be difficult, which is fair. For a lot of times for people, I try to teach corresponding practices, because some people like the sitting and the breathing and they can focus on their breath and they find that comforting and they tune into their body that way. Other times for a lot of people, they have the chronic tension, chronic pain. So to sit and breathe means, oh, here I am. I'm going to start feeling all the aches and the pains and so on and so forth. So it's a very traditional approach, tension reduction. It's progressive muscle relaxation. It's where you pair up breathing and deep breathing with tensing up various parts of the body, and you can go from feet all the way up. And
like a contraction relaxation.
Yeah. Contraction relaxation.
It's like I take my hand and I'll go like this and then I'll let it go. Take my foot.
So for example, like I'll give one of my favorites, because I think we all have these moments when we're frustrated, is you would take a deep breath, hold it for a few seconds, and you'd squeeze your fists, and you'd feel that tension in your hands. You'd feel that tension in your fingers. And you're really body scanning. You're noticing it in your fingers, your fingertips, and your hands, and your wrist. And after a few seconds, you relax. Just let your hands open. And you're going to go through a series of motions in the body like that, with your toes up towards your knees, and then your toes out, and then your legs straight, and then with your abdominal. And you can do that with hands and your biceps. But what that's really doing, one, is you're building tension in essence, and then learning to relax. But you're learning something that some people haven't in a while, which is what's the difference between the two, being tense and being relaxed.
Very good. Muscle relaxation, I've heard of it, but what's the name?
Progressive muscle relaxation.
Okay.
PMR for short. Yeah.
Progressive.
Well, I look at anxiety, and then I ask the patient, when they're anxious in the room with me, to do a body scan and see what's happening in their body. And that's a similar
So there's
concept.
some questions.
Yeah, I noticed.
Rose, I didn't mean to interrupt, dearest.
That's right.
But there's a woman named Daniela Goldfein who's asking questions. I might be related to her, but it's a good question, and I'm happy that she's watching. She's my daughter. And she's so she wants to know, Michael, doesn't that create more negative tension in the body? Which is a good question, but let's explain how it initially creates tension and then you learn relaxation. Can you explain that again?
Well, it's a process of tensing up and relaxing. So it helps actually like kind of focus on that tension. And then with your breath, you're actually focusing on that tension reducing. So there may be actual tension already there, and you're just kind of building it up briefly in that moment. And then in the relaxation, it helps subside. And as you're practicing, excuse me, when you're doing a lot of the tensing up too, that's helping with like lymphatic system, because you're also breathing and you're tensing up, and that's helping to circulate fluid through the body, but also the breathing as well.
Very good. So Kevin, it's so good to see you, Kevin. I haven't seen Kevin in a while. He just wrote an amazing book, I think, about fathers and children or something. I think so, Kevin. And he's a musician, if it's the same Kevin. So good to see you. Has TMS totally rejected the idea of symptoms being distractions from unconscious emotions, urges, etc.? So Rose, I'm going to let you answer that. Does it make sense?
Yeah, well, it's in my concepts, yes, because we have tension in our bodies to remind us that we don't have to think about our feelings. We can our heartfelt feelings. We're into our external feelings. So therefore, it avoids any heartfelt feelings. And Michael brought up the notion about grief and sadness coming up first, and that is so true. That a patient doesn't want to bring up grief and sadness; they want happiness and joy. But the happiness and joy they're deprived of it because of the pain.
Right.
So it's a loop, and it goes around and around. And I'm so unhappy because I've got so much back pain, but in actual fact, I'm so unhappy because I can't access my feeling of sadness. Does that help?
Does that answer your question?
Do you think I've answered the question?
Yeah. It's a very intellectual idea, and I think when we put it into feelings like Rose, you just did, it really makes much more sense. And I'm sure that's where John Sarna would have taken it, the next level. He to the world, and it's not black and white, Kevin. I don't think any of this is black and white. It's an art. We are an art. Our feelings are an art. Our thoughts are an art. It's not science. So I think that, there's not so much rejection. It's just understanding your symptoms, understanding your relationship with pain. Do you find that, Michael, that patients get very intellectual and they don't really get anywhere? They might go round and round and round.
Yeah, it brings up a few things I noticed from my work. And this I learned a lot from my mentor and my colleague, Dr. Stephen Gold. When we look at trauma and we look at people who've gone through difficulty growing up, let's just go with ACEs in general, but specifically household dysfunction. So you have a lot of stress. But there's also a lack of structure, a lack of appropriate modeling going on and things like that. So for a lot of individuals, they're dealing with so many difficulties that one of the things they haven't learned is just like what it is to have regular practice in their lives. We talk about relaxation, so stress management, and like what that is to just have things you practice on the daily to help reduce your stress, which in doing so can really improve the quality of your life. Because when you're not chronically suffering or chronically in pain, which can debilitate living daily, like taking care of your bills, being able to hold employment, being able to have beneficial relationships, that can really improve happiness without even having to go directly to something traumatic or focus on that.
Right. Really good. So Kevin comments, yes, but after searching over and over for emotions and sitting with them, the pain continues, which leads one to believe that there is more to discover.
This is called intellectualization. It's called spending time in your head.
Is that called ruminating?
Instead of your heart.
Ruminating?
Yeah.
Tell us, Rose, how does one get to their heart? Tell us, Rose. How does one get to and stay there?
By noticing. Just notice. With Kevin, notice that there's something else going on inside as well as the pain.
And then what do I do after I notice it?
Let it be.
Let it be.
Just be, yes. And Michael was talking a few moments ago about meditation and breathing. Well, again, let it be. If your mind is racing, notice it. Oh, okay, I'm sitting here, I've got my eyes closed, but I'm thinking about my issues at work. Okay, so I'm thinking about my issues at work. Well, that's okay. I'll breathe in the next breath, and maybe the issues from work will ease. But no, they come back. So breathe again and let the issues from work come up.
Right.
And underneath of that will be some anger or some sadness about the situation. So let it come up. Do the breath again. The breath goes from the nose and the mouth into the lungs, and the lungs bring up the feelings as the breath goes out, and just allow it to be.
Right. Rose and I were talking about, it's almost like our brains don't want to accept the simplicity, because it almost is like, what do you mean recognize and stay with my feelings? Like that is the freedom. And Michael, can you elaborate that on that? Because it is really, I hate to say this, the bottom line.
Well, I want to follow Rose with what you were saying was really well put with mindfulness practice, because a lot of times mindfulness has underlying capacities that we are developing through practice. So one of which is the capacity to observe. And again, it can be a tall order to sit in a moment,
It is.
to
It is a
breathe,
very tall order.
and to breathe, right? To breathe and to observe what's going on in your mind, to observe a cycle of thoughts, and to be okay just observing that. And then there are other capacities that we develop through mindfulness. The next is to be non-reactive. What it is to observe our thoughts, but to notice the feelings we have with those thoughts and to not react to them. Because a lot of times, if we can develop the capacity to observe, we're out there living life, right? And that's the beauty of mindfulness, is it's going to enrich our life and our lived experience, is that we develop the capacity to notice how thoughts, ruminations of the past or the future can get in the way of the present, and continue to kind of keep the cycle going of pain and disconnection and things like that. Yeah.
Excellent.
Can I just add in here for a moment about Michael said about reactiveness?
Mm-hmm.
Often in the room with a patient, you can allow them to see their reactiveness. And that's what I love about having that special moment in the room, and the patient is allowed to actually observe their reactiveness, because then they can see it. But reactiveness is so spontaneous, and it's coming from the hindbrain, it's coming from the
amygdala.
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 Yeah, it's coming from the hindbrain, and what it isn't integrated yet. Can you talk a little bit about that, Michael? Michael's done a lot of research with the prison population and various people like that. So his experience is very broad. Could you talk a little bit about that, and how reactiveness happens with how people get into fights and that sort of thing? Could you explore that a little bit, please?
Yeah, I want to touch on real quick is about the beauty of therapy in terms of having the opportunity to have someone safe and you trust, a therapist that can reflect back to you. Because for a lot of individuals, a lot of us having to deal with difficulties, when we have reactivity, what follows is, because we necessarily don't have somebody reflecting back to us to helping us to understand, is we feel a lot of shame. So with reactivity in our life and chronic reactivity that causes difficulty, we tend to feel shame and guilt about that. But when a therapist is there and someone that can reflect back to you safely, it can help develop insight and understanding and shift those patterns, so that your reactivity can inform you without necessarily sabotaging life. Yes, I spent a considerable amount of time working with adult men and women, and also juveniles as well, in the correctional system here in the United States, specifically in South Florida. So I've had a lot of experience in terms of helping individuals with chronic reactivity, because for a lot of individuals involved in the criminal justice system, reactivity is some component to whether what the offense was or what the predisposing difficulties were in their life.
Do you mean reactivity, impulsiveness? Is that what you mean by reactivity? Like to be impulsive and not and act before they think?
Yeah, impulsivity. Yeah, we go with that.
Okay.
So
go ahead. I'm
a
sorry
lot of
to
times,
interrupt you.
no, you're spot on, because reactivity is kind of a global term.
Yeah.
So a lot of impulsivity, a lot of reactivity to intense emotions, and very quickly to develop intense emotions, because for a lot of people in the correctional system, they've dealt with a lot of suffering beforehand. For forensic populations, I have to say this, is that the rates of exposure to ACEs are nearly double and triple that of the general population.
Right.
So what we're finding in research is that those who have been incarcerated have been exposed to a tremendous amount of adversity from childhood throughout adulthood. But I've spent time on working, and very much the fundamentals, what it is to just sit and talk about a problem and observe what's happening as they talk about it, and then to interweave practices of breathing and meditation, so on and so forth.
Right. Julie has an amazing question. Julie, bless your heart for asking this, but not reacting, especially in a safe place, isn't that repressing your emotions like sadness and loss? So I think Julie might have misunderstood. Correct me if I'm wrong. We want you to respond, not react. We don't want you to not express, but reacting will get the brain going, and responding is just a new habit. Explain that, Rose. What would you say to Julie?
Well, I would say that reacting in the room is awesome, because then the person can see what's happening.
Right.
And then they can turn against it. It's as simple as that, turning against the reaction. I've reacted because you've asked me a personal question.
Right.
So I've begun to become emotionally close to you, and you see me as a danger.
Right.
Okay. Is there a feeling then that I'm going to hurt you when I ask you about your feelings?
I think she might be. I think she might be. She might be saying, if I'm not correct. So at some point, one of us said, "Don't react," and she's saying, "But no, reacting is expressing emotions."
Discharging emotions, it is, not reacting.
Right.
Discharging them, putting them out. You don't know what they are then because you've got rid of them.
Right.
Whereas if you hold them, then you see that you're angry or you're sad.
Mm-hmm.
Yeah, the context.
Yeah.
And also reacting does turn the brain on. Wouldn't reacting make, whenever we react impulsively, or what did you call it, to be, use the word when I said impulsive. Anyway, when we're reacting, my brain's going to fire. My brain's going to, so we're talking about reacting and responding. That's how I explain it.
Yeah, not shutting down. Sometimes it's difficult because even when I hear myself talk in the vernacular of therapy and research and so on and so forth, is that sometimes things sound like all or nothing. But I want to say that it's not all or nothing. It's really not reacting is not akin to shutting down. It's important to recognize the context, right? Because processing and digesting, especially feelings of sadness and loss, are so important to integration and moving forward in a lot of ways. But again, the context of reacting, let's say in a safe space compared to not safe space. But Julie, I saw that you said especially in a safe space, so I wanted to just clarify. Like, no, definitely support that.
Right.
Yeah.
And whenever we respond, we stop, we think about something, we make a conscious decision. It's like a minute of meditation and mindfulness. We're talking about mindfulness.
Minute mindfulness. I like that one.
Yeah. And that's what Rose, Rose will teach a lot of our mutual clients about accepting. And I think this is what we're talking about, right, Rose? Like, people need to accept the situation because we do want to change it. We want to, fix it. We want to, isn't that right?
Okay. Well, the word need is probably our desire, not the patient's desire.
Yeah.
So when we spend time with the patient, we need to be neutral and just help them observe what's happening.
Right.
Because if you want them to recover, that creates a helplessness in them.
Right.
Whereas you want to build their capacity. And that's why ACEs is so important. Right. And that's why I'm very keen to have Michael here, because ACEs is what sets us up for our lives. Right. It's about our attachment and how our attachment has been damaged. And then when you have a romantic relationship, people become helpless because that's what they've had to do when they've been little. When they've been at work and someone's been mean to them, they become helpless again because that's what they've learned. So we have to help them to see that the helplessness hasn't helped them. Right. But if we want to help them more than they want to help themselves, we become frustrated, we burn out as therapists, and the patient doesn't get anywhere.
Right.
So
I
hope that makes sense, that it's a mutual arrangement with a patient.
It is 50-50.
That's right.
So why wouldn't, Kevin wants to know, why when someone starts to feel their emotion, does the pain shift and become worse?
Yeah, it does. Yeah, because they've allowed their feelings to come up, and the automatic reaction, the automatic interactional pattern is to go back to pain. Hopefully we've got someone going to talk about that in the near future as well. Yeah, that normal interactional pattern and how it comes up and it just, wham, it's there before you know it. Exactly. And that's where that reaction, that defensiveness comes up as well, because that's the only way a child has had to cope.
Right. And I want to say to anyone who has pain, it's that I think that we have to have a relationship with the pain that doesn't frighten us and scare us. Now, I know that sounds like I'm simplifying it, but if the pain is not coming from a physical cause, which, again, chronic pain is not normal. Michael, I've never discussed this with you, but chronic pain is not normal. A disc herniation 2 years later is not normal. So I think the person also has to accept, this is one of Sarno's, his tools, accept 100% that the pain is coming from a psychological cause. And then the body begins to relax because the person feels in control. If it's from a psychological cause, I'm in control. Can you address that?
Well, you guys are capturing it as that relationship with oneself, right? We develop a relationship with ourselves. So a lot of practices, especially in terms of mindfulness, can be like just developing a relationship with a specific experience within yourself. Mm-hmm. So like, for example, if chronic pain and it develops a sense of tension within itself to experience chronic pain, right? It's not only we're feeling pain, but we are tense from that pain. Mm-hmm. But if we can be mindful of that and we can observe and develop a relationship with that feeling of pain, we reduce our reactivity to that pain. Mm-hmm. And then that in itself can kind of reduce the experience of that pain. Mm-hmm. And over time, we may find that we're actually functioning in ways we may not before because we've just developed a more calming relationship with ourselves and what we experience.
Right.
Michael, has exposure therapy, has that lost its place now with PTSD? Like, can you talk about that? Because there's a lot of
tension. Yeah.
Yeah. Can you draw on your experience there and whether it's helpful or not?
It's helpful. It's helpful. I think it's always important to make sure, to understand the guidelines for use of specific interventions like exposure. Generally, it requires a certain level of functioning in life because we want to make sure that, doing exposure therapy doesn't run the risk of, what would we say, sending someone backwards, right? Like sending someone backwards.
That's why I'd like you to talk a little bit, maybe tell us how it would send one of us backwards.
What is exposure therapy, please?
Okay, so exposure therapy it's a range of therapies that are specifically focused on a person digesting, processing, therapeutically the traumatic experience in itself. And that can be done in gradations. So for example, a person may not necessarily have to run through the whole traumatic experience itself, but they may start by just talking about prior to the incident occurring and kind of scaffolding as they go through the incident. And for many exposure-based interventions, they will weave throughout the exposure practices or techniques that induce relaxation. So exposure is not a person walking into a therapy room and recounting the traumatic experience, becoming triggered and reactive and upset, and that's it. That's not how it works. It's very graded. It's a patient approach. It does take some time, but it's meant to decondition the PTSD response that a person is typically having and is interfering with their life.
Often when patients come to the rooms, that's the first thing they want to talk about. And for me, I try and avoid that a little bit and go into interpersonal experience for them or how they are reacting to me. And that's why I think this exposure therapy is probably the most commonly practiced type of therapy. And I think if Michael would sort of help the patient sort of see that the scaffolding is the most important part for they to actually look at it. Because my scaffolding is to see what's happening in the present moment rather than go to the traumatic incident, so that the traumatic incident is actually put aside and it's allowed to sort of come up. But I think in your area, which is more about PTSD and acknowledgement of that you work in a stronger, you address it quicker is probably what I'm trying to ask than someone like me.
No, not really. What I tend to find is I work with individuals who have PTSD, but a lot of individuals who have complex PTSD, which is a form of more intense traumatization, chronic traumatization in childhood, adolescence. It could be in domestic violence relationships. And generally, the approach I use is contextual trauma therapy. So I try to first, it's the focus on the relationship and where the person's at in the here and now. Because a lot of times for individuals who've had chronic PTSD or complex PTSD, there's a lot of facets of their life that are not going very well at times. Like a lot of times they have chronic distress, pretty chronically elevated and stressed every day, which is not a good indication of doing any kind of focus on trauma. That could lead to decompensation and then, other aspects of their life falling back. A lot of times it's focusing on where they're at, what kind of life are they living now, what kind of things, if they were in place, would be better for their living. Because at times it doesn't always require to focus on the trauma. But if we focus on what's going on in their life now, scaffolding and creating process, steps, treatment goals that help ameliorate what's going on in the here and now, better self-care, better routine, structure, practices, relationship skills, things like that can lead to a more gratifying life in the here and now. People don't always feel the need to have to go back and process trauma. And especially when we talk about ACEs, household dysfunction, for a lot of people, they've never even known what it could be like to live a functional, gratifying life. So a lot of times through therapy, we focus on relaxation. We focus on good stress and self-care, stress management, self-care routines, which naturally reducing their stress improves their capacity to relate to others and communicate, perhaps feel a greater sense of safety within themselves and move forward in other ways. So it depends. As in all things, it depends.
Yeah. So within a prison population, for example, you would not allow them, or you would move them away from their actual trauma experience back into the present moment, you're saying. I'm just bringing... Yes?
For prison populations, it's quite a dynamic affair.
Yeah.
Because a lot of times...
Share that a little bit, yeah.
Yeah, because a lot of times just the experience that individuals are having when they're incarcerated in and of itself can be a harsh and triggering atmosphere. So a lot of times for people who are incarcerated is like the trauma is always at the forefront of their mind in ways because they are experiencing hostility. They're in their environment when they're incarcerated. They're experiencing deprivation. They're suffering. There's just suffering that a person has gone through that they're still carrying. So a lot of times it's not necessarily wanting to go towards the trauma. Although for a lot of people I worked with, they were like, I just need to get this out, which is always respected. But it's like, what can we start with small that will improve the here and now? Because if we can reduce the impulsivity, the reactivity, the emotional reactivity while you're incarcerated, we're going to reduce the likelihood of you having an altercation, you having to go through other forms of punishment or hostility with other individuals who are incarcerated. So a lot of times it's more of like a prolonged, focus on distress tolerance and interpersonal skills, communication skills, just so the person can experience some sort of, I don't know if calm would be the right word, but just feeling a little bit safer within themselves to manage the environment.
Yeah. Also, do you see patients that are traumatized with a recent trauma, for example? How would you change that? Or like, I've just watched my mother being murdered or whatever. So would you see them within the week? Do you know what I'm saying? A recent trauma and an old trauma is what I'm trying to bring up and examine.
Yeah, usually people who've had a recent trauma. I mean, I've seen people who have a trauma with a couple days before. A lot of times the concern is just the natural stress reactions a person has to a traumatic experience. So they may want to talk about what happened, but then there's also immediate focus on grounding. because paratraumatic dissociation. So for a lot of people who have gone through a recent traumatic event, witnessing a murder, violent acts across the board, horrific stuff will immediately induce protective mechanisms in the brain and in the body to help cope with that response. But it can lead to a sense of immediate dissociative experiences. So a sense of depersonalization, not being in your body. You feel so impacted by the trauma that just recently happened. You feel like you're out of your body. You feel like the environment, derealization, where you are isn't real. So focusing at first on just helping a person stay grounded, bringing them back to realize what has gone on and to slowly digest and process.
Listen, Corona has been. I was just going to say, Corona has been also a big a problem for the world, and so I think
talk about chronic pain and quarantine. Like that's
right.
It's been incredible difficulty for everybody dealing with.
Right. Well, that's how Rose and I got started. But enough, anyway. But so Kevin wants to get something out, which is good. Get it out, Kevin. Express yourself. So Sarno and many other theories talk about some of the emotions being out of awareness. So searching for them or trying to feel them causes more tension, doesn't it? Letting go of awareness seems healthy. Letting go with awareness. So I think you want to read that again for Rose and answer that and let Michael answer that?
Well, Michael just spoke about that a moment ago, really.
Yeah. Let's talk about it again.
That's what Michael was talking about a few moments ago, about how it's the awareness of our bodies, because we're out of our bodies when we're with trauma, aren't we? Because it's part of that fight, flight, and freeze response, isn't it? Vasovagal system. So when you freeze, you're out of your body. Can you actually share that a little bit, Michael? Michael's done a lot of research of late, so that's why I keep pushing the question over to him.
And I'm trying not to rant about whatever comes to mind.
Rant. Rose and I rant all the time.
They're like, go for it. As my blush response, everyone can notice is in full effect today. Kevin, you bring up a good point, which you're focusing on awareness, which is so important, because our conscious awareness has so much to do with our relationship with ourselves and like being able to first acknowledge emotions and then approach those emotions and to be able to manage and hold those emotions and work through them, right? So it's like this gradations of awareness that we're experiencing, which in tandem comes with memories, perhaps memories that'll be associated with the emotions, so on and so forth. So I think that's why it's always good to have a set of practices yourself that focus on cultivating your awareness. So much that goes on in the world, especially today, has so much to do with how our awareness can be conditioned. A lot of us, it's like we're chronically avoidant, or our attention is always distracted, things like that. I'm reading at the same time.
Yeah. Did you just get distracted, Michael?
Got all this association and screens and inattentiveness.
Did you just get distracted on purpose? Blah,
blah, blah, blah.
I think that, again, we're talking about basic human nature. We're living life the speed of light. A lot of us, the people that get TMS, the people that, have trauma and are trying to work it out. I always say they're smart and sensitive people, and they're trying to get to it intellectually. And that's a great part of the way. Yes, I need to be more in the moment. And I remember even reading the books about, be here now. And I was like, this is the answer. If I could just be in the moment and not in the past or the future, everything is perfect. Now, we're not talking about being mindful all the time. We're talking about a balance. I think everything we're talking about here is a balance. And because we're all perfectionists and wanting to get it right, I think if we just focus on moderation and balance, it's the most what's the word? Like self-regulating. One of our guests talked about self-regulating. So if we could just self-regulate to a balance, donuts, tofu, not donuts all the time, not tofu all the time. One guru said, take your food in and get it out. Shouldn't be staying there. Another guru said, chew your drink and drink your food. Like, that's a little extreme, but I'm talking about a certain balance to things, like complete. And I think that our minds take us to extreme, and then that gets people in trouble with pain, to be extreme. Talk about maybe some of your experiences with balance and moderation.
Could I just add that the vasovagal system doesn't allow moderation, because it only allows fear.
Okay.
And
that's the autonomic nervous system.
Shut down.
Right?
So what we're looking at is observing, so that we can get to that balance by observing, by noticing. And that's why I say in the room, when anxiety comes up, we ask, where's that anxiety coming from? Am I a danger to you? Are you a danger to me? And then the patient says, oh, I've never thought about it that way. Mm-hmm. Yeah. And then they can create that balance. Because with anxiety in the room, you're not really going to be able to worry about the tofu or the donut. You're just going to go for the donut or the tofu,
right.
The donut, I'd say, for me.
Stress eating tofu. That would be something else.
Yeah.
I think something you guys were talking about too, it's like implicit, is about compassion, the importance of compassion. Self-compassion, because we're talking about mindfulness, and I know one of the things for me is like, I'll talk about mindfulness and I'm like, yes, mindfulness, it's so important to breathe and this and that, but like I have anger issues like everybody else in the world. And that's like really important, is to understand it's so important to focus on self-compassion in your life, because as you become more present, there's going to be stuff that just you're going to realize in ways as you slow down and you're more present with the world and what's going on around you, that can be aggravating and upsetting. So it's always important to continue to like realize how important self-compassion can be, because it will reinforce your practice. It'll reinforce the capacity to be in the here and now.
Well, that's why I was thinking about those prison population, and that where is the self-compassion there, and where is that self-regulation? Because we're looking at an extreme then, and that's why I sort of keep bringing it up, because in our day-to-day lives we don't actually see this sort of stuff. So, we've got an extreme in your experience that you can bring up and talk about how hard it is to actually step back and observe what you're doing.
Yeah, and for prison populations, if we focus on that, both jail and prison populations, it can almost be a reproduction of the same kind of household dysfunction these individuals grew up in. So not only did you grow up with exposure to ACEs, which is going to be predominantly greater than anyone in the general population, you've had to deal with this intense household dysfunction. You haven't had the opportunity to develop in life and have relationships that help you learn how to see yourself in balanced ways, to appreciate balance in life, to know what regulation, the word regulation, emotion regulation, that may not even be in a person's vernacular because of the life they've had to go through. And then you end up in this criminal justice system, which is still having a great deal of difficulty in the States with rehabilitation and recidivism, people going back into the system again and again. But they're going back into a system that reproduces this dysfunction, which is hostility and aggression and disregard and a lack of compassion in general, which can be really difficult. I know there are some places in the States that are working on new models and trying to do something different. But in general, for a lot of people who are in the criminal justice system, it's almost a reproduction, a cycle that they continue to go through. It's incredibly painful and incredibly, we talk about intergenerational trauma. One of the ACEs I mentioned is having a family member who's incarcerated. So when we think about for a lot of the individuals in the criminal justice system, is that they're going through this cyclical intergenerational process, which is tremendously traumatizing for them and their families. And in order to create change, we have to address these things, which require compassion, which a lot of people could be aversive to in these environments.
This draws me to another question, Michael, about taking children to the prison system to see their fathers or their mothers, what does that do to the child?
That's a great question.
I just feel even sad when I say it out loud.
Yeah.
And maybe that father has, would you say father for convenience?
Most of the time, it most likely is a father.
Yeah. Has maybe done damage at home. And then the child has to be repeated, going back and being reminded of the trauma that started that off.
Yeah. So there's a great deal of loss and inconsistency and pain that children experience. And the confusion of having to see a parent. When you're young, you're 6, 7 years old, and you're seeing a parent in a prison, or most likely a prison, not a jail at that point. Children aren't going to be able to comprehend the context of what's going on. For a lot of children, it's just like, mom or dad, they're not here, but I go to this place to see them. But they go to this place that's, mostly concrete and cold AC and a lot of medication that these individuals are usually put on. And then attempting to have this brief experience of connection with a parent, when really we talk about attachment. Attachment is founded upon so many attuning transactions between a parent and a child.
Can you talk about that, Michael, for a few minutes? Like, when you say attachment, give it a little bit more.
Attuning attachment, yeah.
So attachment, the bond that a child and a parent develop together.
Right.
I mean, it could be in a dyad or a triad, a mother, a father, mother, mother, father, father. I mean, however the attachment dynamics are established in the family, but it's that relationship. It's that powerful bond and relationship a child has with their caregiver or caregivers. And that becomes the framework, the foundation for our experience of the world.
Yeah.
Like when we're held as children and it's safe, we internalize that safety. And then that becomes a framework in which we could think like, wait, it's safe here, and that it's possibly the world could be safe. And that influences the way we relate and connect to others. And vice versa. When children grow up, and it doesn't always have to be physically abusive or sexually abusive. It could just be emotionally abusive, or household dysfunction and or neglect can have huge repercussions on attachment, and thus our feeling of safety in connecting with others, our view of the world. Attachment is, I'm a huge proponent of attachment theory, attachment research, and all this.
And what again should the client, the patient, do when they haven't had a good bond? Love themselves, have a good relationship with their therapist. Give us a little take-home tools for people that are listening.
Yeah. Sometimes, and I think this is an important part of therapy, is that it can be the relationship with the therapist that is the first time in somebody's life that they are developing a healthy sense of attachment.
That's right. And then the lack of trust. The other thing that came up, Michael, while you were speaking was about, and I also brought that up when I introduced you, that we're looking for the love. We're not looking for the break. We're looking to acknowledge the love that the child has. What's happening? What's happening?
Just a glitch. Just a glitch.
Still here. I'm sorry.
Sorry. We're looking for the love, aren't we? Because we're made for love.
Connection. Love and connection.
Yes. Connection, love, and safety.
Yes. Yeah. Say it loud.
Yes.
I mean, there's so much need for this in the world. And okay, you were saying I'm ready to yell and rant about love, safety, and connection.
Go ahead.
Scaring people away as I'm yelling about love and connection. And this, for me personally, I think this is so important because it's easy to get lost in research and vernacular and blah, blah, blah and terminology. But at the end of the day, we talk about therapy. It really is about that experience, about love and connection and safety. And a lot of that, if we haven't experienced that ever in our life, talk about deprivation. To live a whole life without the experience of love and safety, that's atrocious.
Terrible, isn't it?
It's terrible. And a lot of people go through that. A lot of people go through that kind of stuff.
Have healed themselves It's so
Yes.
possible. That's why you and Rose and I sit here, because we know the absolute ability of the human body and mind. It is absolutely the word is a child is very it's because with an R. It's you are able to continually not revive. A child is
Resilient.
resiliency, like over and over and over again. And the brain. Do you have any experience, Michael, with the changing brain?
Oh my goodness. Yeah.
I
How much
mean,
time do we have? Let's get in the
wait,
neurobiology of love and connection.
because I'm also talking about that, the ability. I mean, this is what Joe Dispenza, who's this neuroscientist, and all he talks about is love. This is the scientist who's like talking about quantum physics and energy, and then he brings it down to love. It's like, whoa.
Yeah.
It's amazing. So we have two components to the brain, and as far as changing the brain, neuroplasticity and neurogenesis, right? Neuroplasticity, changing in the wiring, and in neurogenesis, it's a changing in the structures, the neuroanatomical structures, right? And that can happen on a genetic level. And there's research on there that just the experience, like practices, mindfulness, for example, can alter neuroplasticity. So for a lot of people who feel like I'm going to yeah.
Whoa.
Oh, yeah.
Yeah, mindfulness. I'm writing that down. Mindfulness can alter neuro. You can keep talking, Mike. I didn't mean to interrupt you.
So for example, it takes time and it takes practice to do this. But if you consider it, if practicing every day is going to beneficially change the wiring in your brain, think about how powerful that is in terms of self-love. Talk about self-love. Taking the time every day to sit and care for yourself and focus on your attention and your awareness and your intention positively to develop yourself, and practicing these things can really change the wiring in your brain. And not just like one area, we're talking like globally. It can reduce the reactivity in your amygdala, which we brought up earlier, right? It can reduce amygdala reactivity. It can help improve the frontal lobe, a lot of your executive functionings, your planning, your thinking, your ability to control impulses through mindfulness. It can help rewire some of the emotional components of your brain, which isn't just like you're changing the software, because experientially you're able to have a different experience with people, right? And that's going to change your life, and those improvements will carry on. They compound beneficially, not just interest, but practices. But you're also changing the hardware.
Right. And, I have to say something like once I did a course and I was told to look in the mirror and say nice things about myself. And why did I find that so hard? It's not easy. What is that?
That's a great question.
What is that, Michael?
Tova, you have gone to the core of what's going on.
Okay.
Can you talk a little bit about that, Michael? Because that is so important, because that's that self-criticism, or as we would say, a punitive superego in operation. Can you talk about that a little bit?
The inner critic, right? The inner critic.
Yeah.
Self-concept, which has a lot to do with our development and our relationships, our attachment style. A lot of times we talk about our developing attachment with others in the relationships, but it has a lot to do with ourself and our attachment to ourself and how we view ourselves.
Yeah.
Myself included, looking in the mirror. Even sometimes, currently I look in the mirror and I'm just like, oh God.
No.
Yeah. But I mean, that's a part of life. But it's so, what am I trying to say here?
Were you criticizing yourself when you did that? Or you were just realizing you're not, look, it's not comfortable. Number one, I said to all my members of our community, this is a challenge. This is a challenge. Remember, Rose, the 5-day challenge. You need to look in the mirror every day with a straight face and a big smile and say, I think you're beautiful. I think you're handsome. Now, why? I want you to explain, why is that so hard? And
talk about exposure.
I want you to talk about also how beneficial, again, you just said it, but how beneficial it is to love yourself and to visualize it, verbalize it, feel it, touch it, heal it, taste it, it's doing something to your brain.
Make it real. Make it real.
It's doing something to your brain. I need to talk about it again.
Okay, can I interrupt this conversation for a moment? And say, if no one's told you in the past, in your connective safety zone, when you were a little baby, any of those positive things, how are they sitting in your brain right now? And when you look in the mirror, the echoes from the past, there's a lovely book called, I can't think of it now, about ghosts from the nursery, because I'm a midwife.
Wow.
How the ghosts of the parents come back into the present life. So how can you look in the mirror if no one has ever told you that you're awesome? How would you like to be told, oh, you're a redhead. Redhead girls are always naughty. How are you going to look in the mirror and see that redhead? You know, I mean, it's heartbreaking. So when you want to look in the mirror and see that person with red hair, and what, do you dye it so you're acceptable? So that self-love and that self-care has to start with self-acceptance.
Yeah.
Because when you move into all those euphorisms, they're not helpful because they're self-defeating. Yeah. That self-critic that's sitting on their shoulders is back, hammering them. Yeah, you know, you're not good enough. You know, you could be taller, you could have different colored hair. You know, why was I born into this family, etc., etc. Instead of, I'm a beautiful human being that's full of love, because my love has been hidden. It's been hidden under sadness, anger, guilt, grief. But it's a loving heart. And I put this little heart that's been stitched on our Facebook page to remind people that their heart is still there. It might need stitching, but it's still there and it's still operating. And even in your prison population, you know, many of those men and women, they love their children, but they're not able to make it happen so that the child experiences it as well.
Sometimes having a child brings up emotional pain, and sometimes that can get between a parent and experiencing their love with their child. It's the pain of the past.
Well, I find that with breastfeeding, with teaching mothers to breastfeed, and it wasn't until ISTDP that I was able to actually ask the mother, because it seemed too difficult to say, well, you know, what are the problems that you're facing? What are your feelings about it being a mother? What are your feelings about this neediness of this child? And then they say, it just reminds me of how badly I felt as a child. And all this feeling comes up, and then their milk starts flowing, and it's just a beautiful, beautiful experience to be able to do.
Powerful.
You know? Anyway, that's my rant.
We're going to wrap it up a little bit because the questions are quieting down. But I would like to end. We started on hope, and I'd like to end on hope. And I'd like Michael to say something, because first of all, Michael, you did amazing. I know you were nervous talking tonight, and you
thank you.
Right in the face, but could you talk more about
wonderful to talk to you about this?
The biology of hope. The biology of hope. That it's not just it's a thought. It's a visualization. It's your brain is changing. The biology of gratitude. Very important things.
Yes, the small steps that a person can take, that all of us can take, and that's with ourselves in practice. You know, whether that's writing down and just acknowledging positive things in your life, or if you've worked through the exposure and you can get to the mirror and you can be realistic with yourself about positive things. It doesn't have to be grandiose in any way, but just acknowledging the positive things that you can, that you are still here today, that you are still moving forward, that you are doing what you can step by step, and that as you practice and as you make routine and you share in that with others, that you are cultivating like love within your mind, love within your brain through neuroplasticity and growth and change, love in the relationships we have. And so much of who we are is those things. It's our relationships, it's our mind, and it's our brain and our bodies connected.
Beautiful.
So yeah.
Beautiful.
Hope and love.
I wish I could sing. If I could, I would sing, but I'm not going to sing. What do you want to say about Hope, Rose?
I just wanted to mention that I will be here on the computer today, most of the day, and I'll answer any questions, or if anyone needs to debrief or anything, I'll be here. It's 5 a.m., 6 a.m. in the morning here, so I'll be on the computer working for a while. So anyone who wants to either message me there, they're welcome, or do a private message. And if any feelings have come up that are painful for them, they might like to talk about it, because I know that although we've got a group of people talking to us on the side here, there are another group of people that are just watching. If they've got any worries, please write it down or message me. And also we respond to the messages on the Facebook page as they come up over several days. So just know that we can offer you some hope, as Tova said, and that underneath that hope is a lot of love. Over to you, Tova. Over to you, Michael. And thank you, Michael, for your time with us.
You're welcome, and thank you.
Yeah. We will talk about repairing trauma in the next week. I've got a midwife coming on that's going to talk about how parents can actually do some fathering to their children. So I'm looking forward to Carla responding to what the subject that Michael has brought up.
Wonderful.
I'll be tuning in.
Yeah, wonderful. Michael, thank you so much. Good afternoon to you, Michael. Rose, have a wonderful morning. I'm going to quiet down and then go to bed. So we'll see you all next week. And here's to hope. Thank you so much.
Thank you so much.
Yeah.
And love. Love, 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 love.
Love, love, love.
No.